Okay, good day. This is a lecture on CBCTs, next big thing in dental maxillofacial imaging. We start off with looking at why would we need, why do we have such advances in technology? In dental medicine, imaging is a part and parcel of our practice because of technology. We have already gone a lot farther than our traditional plain film radiographs, not just to look at what is on the surface, but what is underneath all of this complex structure. Now, imaging has been there for a while. It is very important in terms of our profession as we have to diagnose and treat a very complex structure. Um, this complexity comes from the shape, the depth, the morphology, and the anatomy of our head and neck. As such, from the old skull x-rays that we have, we've found ways to actually expound it, stretch it, if you will, move into different sites and angles. These are topographical views in order for us to identify uh, key structures that may help in not just diagnosis but also be applied into treatment. That's why a lot of studies have already come up with the importance of quality images together with the knowledge and skill of our clinicians or surgeons in order to come up with a better plan and therefore result in a more predictable outcome. 3D imaging has improved our way of looking into the landmarks or identifying uh, features that before was not easily identifiable with our standard plain film radiographs. Give this, for example, of a case that was shown brought to me initially with a plain film radiograph. I thought what any clinician might initially think of. It was a displaced um, impacted molar, but something with the history as I was discussing with the referring dentist and patient seems to be off. We then took or asked for a 3D image, a CT scan, and what we got was, well, a case of an unusual but not totally impossible uh, ectopic eruption of a third molar. It wasn't displaced, it just erupted somewhere else. And this brings us to the topic of the lecture, where we particularly aim to look or discuss what CBCT, how CBCT works. It's in a simple way differentiating it from medical CT scan. We go into basics of interpretations for three-dimensional images and a little into where it could be applied. Basically, I started off with 3D imaging in residency, during my residency, as we used medical CT scans then for a lot of our oncological works. That was way back in 2004. When 2010, after finishing my residency, I started off seeing or worked with cone beam CT scans. Since I got prior exposure to 3D imaging, it was actually fun discovering how this very small uh, structures compared to medical CT scan produce three-dimensional images, and that's where I started off. So we start off our discussion with looking into 3D images and what it is really about. Well, imagine this particular diagram with a set of these letters. If we superimpose them together, this forms our plain film radiograph, or represents our plain film radiographs. We see superimpositions of something three-dimensional. Well, we see overlapping structures. And again, with the complexity of our head and neck, we see this a lot compared to, let's say, other structures in the body. Now, with 3D imaging, what we could actually get is a slice of it, technically getting a cross-sectional image. Now, one of the biggest difficulties in terms of interpretation and big difference between interpreting our old two-dimensional picture and 3D images is that what we see in 3D imaging are cross-sectional images, a clear cut of a picture coming from a three-dimensional object. Again, what this slide represents is our three-dimensional object corresponds to the two-dimensional overlapping image of our plain film radiographs. What 3D images does is it allows us to get a cross-section of that 3D image and see it as a slice or as a cross-section of the entire image itself. Now, it might seem simple at that, but in terms of utilizing it properly for interpretation, that's a different story because we are sometimes used to looking at the entire image or the entire two-dimensional picture of our three-dimensional object that when we take a slice, a peek of a piece of that three-dimensional object, we sometimes lose ourselves to what we are looking at. And that's why it also takes a little bit of understanding what we actually see in order to properly interpret three-dimensional image. But this slide actually just pertains to how 3D imaging is used. Now, that is how we use 3D image. Now, when we look at how we get this clear-cut cross-sectional picture, well, we have to look into how could we turn a picture to three dimension. How do we see depth? Now, for millennials, we know this as an example of a picture coming from Facebook. Facebook has come up with a 3D function. You will be able, with that feature in Facebook, see a depth. But in order for Facebook to actually do that um, particular algorithm, it has to determine depth, which one is in front of which. That's why it's usually possible nowadays with smartphones that has more than one camera because it sees depth. It determines, at least for Facebook, which object is in front of which. And using that, Facebook can now try to allow it to move differently and give this virtual 3D appreciation of a particular object. Now, in terms of scanning, when we'd like to see or get a three-dimensional picture for whatever purpose we may have, we see three-dimensional scanners like handheld scanners such as this, and we see in order to get particular depth, it has a series of X-rays, series of cameras. In order to get a three-dimensional picture or scan of something, we already know that we need to get or use a scanner and get a picture of the entire three-dimensional picture object. So it's oftentimes in a jig like this where the scanner or the object moves. It's either this would be a turntable that would move your object, allowing the camera to actually take a picture of every side of that PD object and then transmit it, reformat it to an actual 3D image or picture. We see a lot of DIYs where cameras could actually be placed on a jig in order to do the same thing. Now, this comes not as a new technology, but as something that has already been used before. Remember our panoramic radiograph? It was revolutionary at that time when we had the ability to stretch the entire jaw and get a panoramic view of it. That was possible when we utilized your X-ray and allowed it to move around the patient's head. Now, that then was utilized in order to get, well, a panoramic view of your patient. When we take that into the aspect of how we could get three-dimensional images, if imagine we take an X-ray, place it on a series of detector, and allow the series of detectors, such as this in this diagram, receive images at different points of the object, then you see different areas of the object, and it would be detected by the series of detectors. Now, have it move around the object, just like what your panoramic X-ray would do, then you'll be able to get all of this series of varying images around an object. And this is how CT scan was able to get a series of X-ray images of the object itself. Computers, especially with newer computers now, had just simply to collate all of these images and compound it to a single image, literally taking all of the different pictures of the ob taken from the object and putting them all together, pasting it in order to get a picture of the entire patient. So that's why if you look at CT scans now, medical CT scans would have something like this, where you would have fixed detectors, and from that fixed detectors, you would have similar configuration. You have a patient at the center, you have an X-ray on one side, a detector array on the other side, and then as the X-ray moves around, it sends out an X-ray image and will be able to be detected by an opposite detector. Now, as the X-ray moves about, it sends out again that same X-ray that's detected by different fixed detectors around. And that's basically how you get a three-dimensional picture of a particular area of your patient. Now, of course, it will be useless to just try to get one a part that has been detected. So in order to come up with a CT scan, a three-dimensional image of, let's say, the head, the CT scan has to take multiple shots. And what happens is patient moves and is being reshot in order to get a three-dimensional series of slices of, in this case, the patient's head. And what this does is it produces a consistent image that you would see on your patient. You would see a three-dimensional slice of a patient that can be compounded, and that would develop into a three-dimensional picture of your patient. This produces a very consistent appearance. But as we remember, X-rays are not linear. X-rays, in terms of its physics, is actually will produce, well, a cone of radiation. However, although it produces an entire cone, since the detector is set on a predetermined site, that means that as the tube or the X-ray moves about, only a specific line of the X-ray will be um, taken. This produces the consistency in CT scans because it only gets the specific X-ray every single time. It will not take anything from um, any part of the X-ray. It will only detect a specific area. And this brings about also one of the disadvantage of CT scans because it has a fixed detector that will only detect a portion of the entire X-ray, it allows certain areas to be re-exposed to the same radiation. And that is where you get advantages and the disadvantages of computed tomography. Definitely, the greatest advantage is creating a three-dimensional image, a multiplanar image of your patients. This is something that is um, a far outcry from the old two-dimensional plain film X-rays that we have, or radiographs, sorry. Uh, because of that, we have greater geometric precision. We could see what is underneath, what is behind, what is above, below, medial, lateral of something. It now gives us the ability to look into our patient like never before. Because of that, also, soft tissue, subtle changes, and contrast can be differentiated. CT scans is able to differentiate subtle differences as that of fat, blood, gas, varying densities in bone, in pathological structures. But because of how CTs are made, as that advantage of CT scan is there, it has disadvantages. Like what I've said, because it re-exposes the same area over and over again. Because in order to get the entire skull, entire image of the skull, it needs to get a lot of or a series of layered shots. Remember, the detectors are fixed. The patient is the one that moves across. So areas that are not exposed to the detector's line of sight will have to be retaken in order to take the entire skull. Another disadvantage, because it retakes a lot of these images per layer, when it sees metal, as we remember from basic radiation physics, a lot of the X-rays would actually bounce back from the metallic restorations. And thus, one of the inherent disadvantages of CT scans, especially within our region, is that when a patient has a lot of metallic restorations, you end up seeing a lot of scatters, a lot of artifacts, to a point, if there's so much metallic restorations, CT scans might eventually become useless in terms of diagnosis because you cannot see anything. You only see scattered images, artifacts that form as metals reflect back, well, the um, X-rays that we send out. And this is again repeated again this, because of the engineering of CT scans. So again, advantage, it has very good um, appreciation to the subtle changes of different densities, even fluids. It also could see, because of how it takes the image, three-dimensional objects, good geometric precision, but it comes to a disadvantage. That's where CBCT comes in. Because of CBCT technologies, one of its particular advantages most CBCT companies would like to highlight is that it produces three-dimensional images, but it has a significant reduction in its radiation. So if we look at how was this able, I use this YouTube animation and actual shot of how CBCT is taken. It actually utilizes the entire cone beam of our radiation. In this case, if you look at how most CBCTs are taken now, it is taken just like our panoramic radiograph. Instead of moving the patient across a central beam that takes one layer at a time, you allow the patient to be still and you have the machine that moves around instead of a fixed array of sensors. You move around with the sensor itself, and the computer just simply adds on all of the images that it gets. Most of these CTs gets more than 200 images. Because of advances or technological advances in computing, it is able to recognize which side was taken at what point. And then it just simply stitches everything together to create this three-dimensional image or three-dimensional view of your patient. Because it utilizes the entire cone beam of your X-ray, it ends up having a faster scanning time. Instead of scanning one layer at a time of a patient's head, you could scan the entire head in one cycle or rotation. This faster scan time will definitely result to a lower radiation dose as you do not require to re-expose the patient again and again. That is basically the big difference between CBCT and CT scans. Uh, this slide particularly shows the schematic representation of the difference between how CT scan gets its image versus CBCT. It follows the same idea that in order to get a three-dimensional picture, you need to get the picture of the three-dimensional object by getting all angles or side of that object. So both of them would have this particular idea of the X-ray source moving about the patient, exposing and getting a picture of all of the sides or angles of the patient. The difference, however, is that in a medical CT scan, like what I've said earlier, it would have a fixed size detector that would only detect a certain point of your X-ray. And therefore, it provides consistency because it will get the same area or utilize the same radiation dose every single time. Uh, With CBCT, what happens is they made a larger detector, the size to which you would like to take a patient's the size to which you would like to have or see on a patient. And because it has a larger detector, it could get or detect the image that is produced or seen by the entire cone beam. Okay? Now, if this is the case, why not just simply use cone beam technology every single time? Because nothing comes without a cost. Yes, CBCTs have a faster scan time because it utilizes the entire cone beam as compared to using just one specific line of the radiation of X-ray produced as it as the detector gets it, but it comes also at a cost because you get the entire cone beam of your X-ray, you do not get as much precise amount of radiation but consistently across the entire cone beam. Because of that, the detector de cannot discriminate or detect varying or subtle changes between one area to another. And thus, it results to one of the disadvantage of cone beam CT scan, wherein it runs faster, but it doesn't discriminate soft tissue as good as medical CT scans. Because also of this particular concept, yes, it has very good definition in terms of its soft tissue, in terms of its hard tissue. You could see your bone in good detail. But because again of the variance in the amount of radiation sent and detected by your detector, it has very limited, for CBCT, bone density measurements or density measurements, which we later on will pass or discuss in terms of diagnosing or interpreting CT scans. So another thing that we have to look into in terms of interpreting is what we term as field of view. Field of view is nothing but what we could see with your CT scans. For field of view in three-dimensional images, it is a term that refers to how much we see or the volume that we see. It is determined by, for CBCTs, the detector size. The larger the detector is, the larger the field of view that you may have. For newer CBCTs, it may also refer to or could be changed depending on the beam production and geometry. So that means even if you have a large detector, if you would have, or if you would change the geometry of your beam together with its collimation, size, and its particular direction, then you could get a smaller FOV. This is what I'm talking about. This represents CBCT's ability to get three-dimensional picture of varying fields of view. This simply means that if I'd like to get a three-dimensional picture of, let's say, about 3, 4 teeth, then I may ask CBCT to take a 5 by 5 centimeter picture of your patient. Now, this would just be able to us to see, well, varying areas in 3 dimensions, depending on what we need. That is basically the field of view for CBCTs. In terms of why we would use CBCTs, this um, 2009 publication in the International Journal of OMS cites the use. And although the use of CBCTs has expanded dramatically in the last decade or two, by far the most common clinical applications we still see where CBCTs is used is in the field of implantology and to assess impacted tooth in relation to um, anatomical structures, particularly mandibular third molars in relation to the mandibular canal that houses the infraalveolar nerve. One of the problems that is perennial to CBCTs up till now is the distortions in the Hounsfield unit, and therefore estimations for bones density and density per se for this three-dimensional image is still far from what medical CT scans can do. And thus, that is where there is still the need for medical CT scans. There is an indication for CBCTs. No three-dimensional imaging modality outweighs the other because as one have its advantage, it also has an inherent disadvantage. You get a better, more predictable um, result with medical CT scan. That's why you get the ability to notice subtle changes between tissues, but it has more radiation. It takes longer. CBCTs have faster scan times, but it does have disadvantage as it only could see in greater detail bone, hard structures versus soft tissue. And that's where, again, CBCT is more valuable. Hard tissue definition, as in this particular case that I'm showing. In terms of when could it be used or better used, the American Association of Oral Maxillofacial Radiologists way back in 2012, and this hasn't changed as much, has pronounced that in terms of in terms of determining when CBCT would be a better option as compared to, let's say, our periapical radiographs and other radiographic modalities. They have still reiterated that the principle of ALARA, as low as reasonably achievable, still takes effect. And therefore, way back in 2012, they have already pronounced that in terms of CBCT, it is not an ideal imaging modality as an initial diagnostic imaging, except for implant site assessment. For those that does implants, this would be very logical as in the past, when we take plain film radiographs, we oftentimes would see only a limited amount of bone since we need to have a general idea of the three-dimensional morphology of our implant site. Um, Plain film radiographs before cannot be a sole determinant or diagnostic aid for implant site assessment and planning. That's why cross-sectional images used or gathered from CBCTs is an important tool even as a preoperative diagnostic for uh, implant site assessment. Okay? And that is where, up till now, it is highly recommended. So again, the advantage of CBCT is that it is very interactive. Although interactivity is apparent with CBCT softwares that comes together with all CBCTs, it is not exclusive. You could actually have the same interactivity even with medical CT scans, but it has to be in their console. Now, for those who know or have the software um, to be able to convert your DICOM files, even from medical CT scan, such as in my case, interactivity is apparent. It's something that could be done both on medical CT scan images with DICOMs and with your CBCTs. But again, the importance is with interactivity comes the ability to plan ahead of time your surgeries, could allow us to assess, even diagnose our patient at the comfort of our own home without actually being in the hospital or in our clinics when we'd like to look into three-dimensional images for purpose of diagnosis or even planning.